Inr, we're live.
Good morning, everybody. A very warm welcome to you all to the second session of the day in the SCTS INSQ University. I'm Indu Deglurkar, one of the chairs, and I'm accompanied by Omar Navetu, Dr. Torsten Donst, and Marcus Solinas, who are co-chairing this session. And I'm very pleased to say we have 4 exciting talks lined up. And the first one will be on the mechanical valve as the best option in young patients, and that will be by Mr. Norman Briefer. The second talk is going to be on aortic valve endocarditis, technical tips by Mario Petro. And the third talk is Ozaki operation for acquired aortic valve disease, technical considerations and the evidence. And the last talk of the session will be by Dr. Degeneration, and it is on anatomical dissection of the aortic root, anatomical dissection of the aortic root for aortic root and valve repair. So first and foremost, I would like to welcome Mr. Briefer and give us a talk on mechanical valve, still the best option for young patients.
Hello. Do you think the mechanical valve prosthesis is a relic which belongs in a medical museum? I don't, and over the next 15 to 20 minutes, I hope to persuade you to my way of thinking. My name is Norm Briefer. I'm a cardiac surgeon and university reader in Sheffield, and I would like to thank the Society for asking me to talk about this topic. So these are my disclosures. I sit on the NICE Guideline Committee for Heart Valve Disease, and I'm associate editor for the Heart Journal, so I consider myself reasonably well informed. This is the agenda I will follow for my talk. Talk about the PICO principle, which I will define. I will talk about changes in current practice in the United Kingdom. We'll obviously talk about the guidelines as they exist today, the evidence behind the guidelines, and we'll talk in greater detail about the Achilles heel or weak underbellies of the modern prosthesis. And finally, make some predictions about the future. So the PICO acronym is used very often in trial design to define a research question. P stands for population, in this case, patients under 65 in high-income countries, especially specifically the United Kingdom, undergoing aortic valve replacement. Predominant mitral valve pathology in this age group, as you know, in high-income countries, is mitral valve prolapse, and 90% of these patients undergo or should undergo mitral valve repair. I is for intervention, which in this case is implantation of a mechanical prosthesis. C is for comparator, which in this case is a tissue prosthesis, which could be either a pericardial or a porcine stented tissue valve. And finally, O is for outcomes, which traditionally is survival. Structural valve deterioration as defined by need for reoperation and anticoagulant related bleeding. In the United Kingdom, the height of mechanical prosthetic valve use in the under 70s, as seen on the top line, dotted line, was as long ago as 1995, and there's been a decline ever since. This is current data from individual databases of 6 large units around the country. These are patients in the 50 to 69 age group undergoing isolated aortic valve replacement, and tissue valves are represented in the blue bars. And in 15 years, as you know, the use of tissue valves in this age group has doubled. And there's a similar rising trend for patients undergoing mitral valve replacement. This is latest data from a recent NICOR report, and it shows extraordinary variability across the country. So at the top comes King's College in London, where 74% of patients under 60 undergoing aortic valve replacement get a tissue prosthesis. And it gives me great pleasure that on this occasion, Sheffield comes bottom of the class with 15% of the same group getting a tissue prosthesis. So these figures give rise to 2 fundamental questions. Number one, what has changed over the past 20 years to explain this inexorable rise in the number of tissue prostheses in the young? And most obviously would claim the reason is that patients don't want to take any warfarin anymore. In which case, are patients and NHS anticoagulant services so different in Sheffield from those in London? I would suggest that what has changed over the past 10 to 15 years is the behavior and attitudes of surgeons. So let's look at the guidelines, because they clearly also have changed. And we'll start with the European guidelines, which were published last in 2017. So these are the indications for mechanical prosthesis. 2, as you can see, have a class 1 recommendation, and 3 have a 2A recommendation. And they are the desire of the patient, no contraindications to anticoagulant therapy, patient at accelerated risk, or rather at risk of accelerated structural valve deterioration, patients already on a vitamin K antagonist because of mechanical prosthesis, patients under 60 undergoing aortic valve replacement or under 65 undergoing mitral valve replacement, patients with a reasonable life expectancy or where future redo would be high risk. So since 2014, there have been 3 versions of the US American College of Cardiology guidelines. 2014, and then in 2017, there was the focused update, and the latest, hot off the press, which I published last December 2020. So to summarize what both sets of guidelines, the European and US guidelines say, there's shared care decision-making and absence of contraindications to oral anticoagulation are prioritized in both the European and US guidelines. There are no class 1 indications to implant a mechanical valve in the US guidelines. Whilst the age cutoffs for tissue prosthesis in European guidelines are 60 for AVR and 65 for MVR, the corresponding ages in the US guidelines are 50 for AVR and 65 for the mitral. They do state, however, that between the ages of 50 and 65, in the absence of contraindications to oral anticoagulants, either would be a reasonable choice. So let's look at a primary source of evidence. Firstly, 2 key randomized trials comparing outcomes after aortic valve or mitral valve replacement with either a tissue valve, a Hancock porcine valve, or a mechanical Bjork-Shiley tilting disc. These trials started in the late 80s and were published in the noughties. Patients were followed up for 15 years in one trial, 20 years in another. This kind of trial will never be repeated. This is why the findings of both of these 2 trials are still so important. And in both trials, most patients were under 65. So this is the first trial. This is the US VA trial. And the conclusion of the authors was that in the absence of contraindication to anticoagulant therapy, patients under 65 who require aortic valve replacement should be advised to have a mechanical prosthesis because they had an improved survival with negligible need for reoperation. They did, however, as expected, have a higher rate of anticoagulant-related bleeds. The second trial was the Scottish trial, and this was followed, the patients were followed up for 20 years. Patients undergoing aortic valve, mitral valve, and double valve replacement, and the authors recommended that mechanical prosthesis should be used in all patients having mitral valve replacement, and then those patients undergoing aortic valve replacement if they're expected to live 10 or more years. And the evidence from these 2 trials essentially dictated practice over the next 20 years. Now, since the publication of these 2 very important trials, there have been 2 types of publications on prosthetic choice in younger patients. The first was simulation or modeling studies, which use data to establish the optimal crossover age in patients undergoing aortic valve replacement. The first one is this one, which was a UK study from a UK registry. They concluded that the patient age when event-free survival, event being defined as a death, a bleed, or reoperation, was better with tissue prosthesis was 67 males, 68 in females. And then this very similar Dutch study, the equivalent crossover age was 60 to 63. There have been no modeling studies for mitral valve replacement. So despite the recommendations of the randomized controlled trial, surgeons continue to implant both types of prosthesis in younger patients. And therefore, over the years, there have been multiple papers that have compared retrospectively outcomes in younger patients in the 50 to 70 age group undergoing aortic valve replacement with either tissue or mechanical prosthesis. And the student of mine, Charlotte Holmes, she performed the formal meta-analyses of all these papers. And the forest plot shows survival favored patients receiving mechanical prosthesis, bleeding complications favored patients with tissue prosthesis, reoperations favored those with mechanical prosthesis. So when you combine survival, bleeding, and reoperation into one big mega outcome, there was no significant difference between the 2. So what these retrospective studies confirmed was the findings of the randomized controlled studies. I also want to briefly mention endocarditis as an outcome. Now, all of the studies, including the randomized controlled studies, have shown a higher, albeit non-significant, higher incidence of prosthetic valve endocarditis in tissue devices. This letter was published in Circulation fairly recently, reporting analysis of the large Swedeheart registry, which is a well-validated national registry from Sweden. And after adjustment for different variables, including age, which is a very fairly strong risk factor for endocarditis, the incidence of prosthetic valve endocarditis was indeed higher in patients with tissue devices. So let's look at, in greater granular detail, at the shortcomings associated with the two types of prosthesis we're talking about, starting with anticoagulant-related hemorrhage, which is the weakness of patients with mechanical prosthesis. So this was the first study published in New England Journal of Medicine in 1995 to examine the optimal levels of INR required for patients with mechanical valve prosthesis. This is a combined incidence plot of embolic and hemorrhagic strokes against INR, with embolic strokes on the left associated with low INRs and hemorrhagic strokes on the right associated with high INRs. And the safe INR range at the bottom there was between 2.5 and 4.5. There was a subsequent retrospective study called the Usva study from France and the Gilia study from Germany, which demonstrated that with modern bileaflet mechanical valves, it was possible to drop the INR to 2.5 and to decrease the bleeding rate without incurring an increase in embolisms or emboli. Two subsequent randomized control studies went even lower. There was the lower IT trial from Italy with St. Jude prosthesis, and the better known PROAX study with the Onyx prosthesis. And they showed that you could drop the INR even further to 1.5 to 2 without incurring an increase in thromboembolic events. We also know from Eric Butchop's work in Cardiff that INR variability is very bad for patients with mechanical valves and is associated with decreased survival. And one way you can get constancy and decreased variation with your INRs is to actually use point of care or home monitoring of INR, which is vastly underused in the NHS, even though it is funded. And to very briefly talk about DOACs to prevent thromboembolism in patients with mechanical valves. This was the Realign study, again published in New England Journal of Medicine, which looked at dabigatran, which is a thrombin inhibitor. And really the only way to describe the performance of the drug was disastrous, because patients on dabigatran had both higher rates of bleeds and higher thromboembolic events than patients who took warfarin. This is a very good paper, again published recently in Circulation, that looked at future potential of DOACs in the field. Certainly CryoLife, or the makers of the Onyx valve, should be commended for being brave, some would argue stupid, to try again using a apixaban, which is a factor 10 inhibitor. And there's no doubt that if the study is positive, this could be a real game changer, not just for Onyx valve and CryoLife, but for mechanical valves in general. For me, it will make my life easier trying to persuade people to put in more mechanical valves. So related to potential use of DOACs, and that's confirmed by the Scottish study, patients undergoing double valve mitral, and to a less extent aortic valve replacement, will not avoid anticoagulation forever. There's a huge, big rapid rise in the prevalence of atrial fibrillation after the age of 65, and the odds of getting atrial fibrillation are increased threefold if you have valvular heart disease. And finally, the last point about bleeding and oral anticoagulants is the attitudes to oral anticoagulants. This is being formally studied in patients with atrial fibrillation. And there's no doubt that the risk of anticoagulants, when they do occur, are very visible, but they're nearly always exaggerated by both medical staff and patients. Whereas the benefits, i.e. prevention of strokes, are invisible and tend to be downplayed. So the flip side of bleeding is structural valve deterioration, which is the weakness of tissue valves. Most tissue valves will degenerate if left long enough. It's a bit like prostate cancer. All men will get prostate cancer if they live long enough. And the question one has to ask is whether the prosthesis will outlive the patient or vice versa. We know that in the absence of coronary disease and in the presence of normal left ventricular function, aortic valve surgery often restores life expectancy to population norms. Now, this is UK data, which shows a steep rise in life expectancy for a 65-year-old man. And in 2021, a 65-year-old man or a 65-year-old woman in the UK is expected to live for longer than 20 years. And although most, if not all, tissue valves will degenerate given enough time, they certainly don't degenerate at the same rate. And we are beginning to understand the risk factors for accelerated degeneration. And any degree of patient-prosthesis mismatch is one of them. So prostheses that are mildly obstructive at the end of surgery are at increased risk of leaflet calcification and progressing to moderate or severe stenosis. Another risk factor for accelerated structural valve deterioration, as demonstrated by Pibro, as well as in a study by an intercalated student I supervised a few years ago, is diabetes mellitus. And as the European guidelines state, a patient who's at risk of accelerated structural valve deterioration should, in the absence of contraindications to vitamin K antagonists, be encouraged to have a mechanical valve prosthesis. And we are entering a golden age for those interested in heart valve disease. For the first time in 50 years, since rheumatic heart valve disease was sorted in higher income countries, the incidence and prevalence of heart valve disease is increasing. Cardiologists, both interventionalists and imagers, are now very interested in heart valve disease. And the way patients are being managed is also changing rapidly with the advent of heart valve clinics and increased surveillance. What this means is that prostheses, all prostheses, including tissue prostheses, are under the microscope in ways they've never been before. And what this means that structural valve degeneration is not just defined by what is found at reoperation, but by what is demonstrated at echocardiography. And Danny DeVere, who's an excellent interventional structural cardiologist from Seattle, has devised a very useful staging system to define and to grade tissue valve dysfunction in this paper. And certainly as an editor, I would probably turn down a paper that defined structural valve deterioration solely as a need for reoperation. Philip P. Barreau from Montreal in this paper has demonstrated early echocardiographic evidence of tissue valve dysfunction in a very significant proportion of patients. Now, there's no doubt that the emergence of valve-in-valve technology has added rocket boosters to the trend for implanting tissue valves in younger patients. I personally am unsure how this will play out. Maybe an unpopular opinion, but I personally don't think this will be a game changer for a number of reasons. First, a significant percentage of implanted tissue valves demonstrate a degree of patient prosthesis mismatch already and are probably unsuitable for valve-in-valve. Then there are issues with leaflet thrombosis, so-called HALT, or hyperattenuated leaflet thickening, as demonstrated on CT, and possible need for oral anticoagulants. And there's still a lot of uncertainty, if you read literature, on the ideal antiplatelet anticoagulant combination these patients should be taking. And if you look at real life experience, so this paper, again, published fairly recently in JACC, so this was a cardiology paper, and this reports outcomes for a very large real-life retrospective French study. This was a national registry comparing outcomes of two propensity match groups, huge groups, 700 in each, over 700 in each, and they're going either valve-in-valve or reduced AVR. And these findings are sobering. So the red lines for valve-in-valve patients with all outcomes. So all deaths, cardiovascular deaths, atrial fibrillation, rehospitalization and permanent pacemaker, all being much worse in the valve-in-valve group within 2 to 3 years. And therefore, valve-in-valve really should not be a reason to implant a tissue valve in the young patient. So let's look at the future. And it's good to start by defining a perfect prosthetic valve, which would be one that has a large enough effective orifice area when opened, does not leak when it closes, performs optimally for decades, and does not require anticoagulation to prevent thromboembolism, and is resistant to infection. Essentially, this would translate to a tissue valve with a large effective orifice area whose leaflets never undergo structural valve deterioration, or a mechanical valve that requires no or very low levels of easily managed anticoagulation without sustaining thromboembolic episodes. What I can predict is that this perfect prosthesis will never be delivered on a catheter. Warfarin is problematic, and apart from point-of-care testing and factor 10 inhibitors, solutions may include ticagrelor, which is a vitamin K antagonist drug, which unlike warfarin is unaffected by P450 and is therefore not subject to genomic differences in metabolism, as well as better and safer tests for assessing warfarin activity, such as this fixed PT test for monitoring activity, for monitoring warfarin, and this was associated with improved outcomes in atrial fibrillation. Developments in the tissue prosthesis world include the introduction of anti-calcification techniques used most commonly most recently RADA and the Inspiris valve. The problem with tissue valves is the material, pericardium, and so companies are now looking at polymer substitutes like this Trial valve made by a company called Folix, which has been implanted in humans, and the UK polyvalve, which Professor Ashona will be talking to us next Tuesday. I think there'll be improvements in the way care is delivered with new NHS integrated care organisations and resuscitation of the cardiac networks. We'll also see the advent of so-called precision or personalised medicine. This is a good review in the European Heart Journal. This was a PhD project, which I supervised, and the potential for computer modelling to predict not only the precise hemodynamics of any particular prosthesis implanted in a particular patient, but you can also model and predict the clinical benefit that a patient will get. And it does work. It is quite extraordinary. And finally, money. Healthcare is now much more expensive because of COVID, and the country is broke. So finally, in summary, I hope I've demonstrated that younger patients undergoing aortic valve replacement live longer if they receive a mechanical prosthesis. Anticoagulation can be safe. Patients are living longer with their prosthesis. Many of these patients will develop atrial fibrillation and require anticoagulation anyway. Structural valve deterioration will be diagnosed more frequently, and valve-in-valve is really not a good idea for young patients. So, in answer to the question posed by the title of this talk, yes, mechanical devices are still the best choice for patients undergoing heart valve replacement. Do not seek patients' preference until they have been fully informed. And they have to be fully informed about everything, about the pros and the cons via the device, which includes survival and healthcare needs associated with either type of device. Bleeds on the one hand, increased surveillance, possible redo surgery on the other. In my own practice, barring any contraindications, as we have discussed, to oral anticoagulation, my cutoff age is 65 for patients undergoing aortic valve replacement and 70 for the mitral valve. I'd like to thank these colleagues for lending me the data to talk about current UK practice. Thank you.
Thank you very much for that, Norman. Excellent talk. I've just been reminded that there'll be a poll that appears on your screens. Could you all the participants in the room, please do take this poll and give us your feedback. We'll move on to the next talk now, that is aortic valve endocarditis, technical tips by Mario Petro.
Hello, do you think the mechanical valve prosthesis?
Chairman, ladies and gentlemen, friends and colleagues, I'd like to give you a brief overview of the technical aspects associated with aortic valve and aortic root endocarditis surgery. Now, the types of operations we perform on these patients is largely dictated and guided by the pathoanatomy that is presented before us. And this can range from very simple cases in which there is isolated involvement of the native aortic valve cusps to more destructive lesions associated with abscess formation, and ultimately the very complex cases in which there is aortoventricular discontinuity, fistulation, mitral and tricuspid involvement. And these latter scenarios tend to be associated with prosthetic valve endocarditis, particularly in patients who present relatively late. In terms of the basic principles, it is important to have TOE or transesophageal echocardiography available preoperatively and intraoperatively so that we can assess precisely the valvular lesions, the presence of aortic root abscesses and fistulation, as well as to assess the general cardiac function. Most of these operations are performed through a full stenotomy or re-stenotomy on full cardiopulmonary bypass. I tend to favor the use of bicaval cannulation with snares, particularly in redo cases, because it's not uncommon for the right atrial appendage and cavo-atrial junction to be firmly adherent to the aortic root, which can make access very difficult. And in order to expose the depths of the aortic root and the LVOT, it's not uncommon to inadvertently enter the right atrium. Antegrade and retrograde cardioplegia is the standard, particularly cold blood cardioplegia, and it is important, particularly with the more long and complex operations, to be very strict about the protocol for the maintenance doses, as suboptimal or poor myocardial protection can be one of the Achilles heels for these patients. Aggressive debridement of all infective and necrotic tissue is the basic surgical tenet in endocarditis surgery. And once you've done this, you assess the situation in order to guide the next steps, which may involve a simple isolated aortic valve replacement all the way to the very complex type of operation, including the commando procedure, which we shall mention briefly towards the end. So this is the, if you like, level 1 type of case, where you have destruction mainly confined to the aortic valve cusps, which have been excised, and the aortic annulus is in the main intact. Now, if you encounter a small early abscess with a very shallow cavity, it's not unreasonable to use a patch technique to exclude this from the circulation. A couple of things I would say about this. One, try and be relatively generous with the size of the patch. I think if you make it too small, by the time you've sutured it all in, what you end up with is a much smaller effective annulus, and you may be in a situation whereby you will end up putting quite a small prosthesis in a relatively big patient, which could be a risk factor for patient prosthesis mismatch. Secondly, it is important to get a very perfect seal with the suturing of the patch, because if you leave any persistent communications between the LVOT and the abscess cavity on the other side of the patch, this may be a risk factor for reoperation due to false aneurysm formation. For more complex cases, such as prosthetic valve endocarditis with aortic root abscess formation, the surgery is clearly more complex. Here we have a very nice example of a PET CT scan, which shows the high avidity in the region of the aortic root corresponding to the root abscess formation in a patient with active endocarditis. And a CT scan preoperatively is very important, again, as part of surgical planning. A lot of these patients have had previous aortic root and ascending aortic surgery, and if they have infected grafts, it's not inconceivable that they may also have a false aneurysm lying in close proximity to the sternum. That in turn will help guide the cannulation strategy. Transesophageal echocardiography, again, is the sine qua non for this kind of surgery. A-protein in use is to be recommended as the standard antifibrinolytic in these cases that are at risk, of course, of bleeding complications. They can be very long bypass times, and these are patients who by definition are inflamed or infected, and in combination with a long bypass time, it's not unexpected entirely for them to have a systemic inflammatory response syndrome requiring high doses of vasoconstrictors, including vasopressin. I would say that nowadays these sorts of cases require double scrubbing with 2 experienced consultants as the standard of care. And the options for patients with complex aortic root endocarditis are varied. Again, one could try and keep things simple and try and reconstruct the aortic annulus using extensive patch reconstruction and then insertion of a standard prosthetic valve. In my experience, I think if you have to reconstruct the entire annulus circumferentially with involvement of the LVOT, this can take quite a long time, and personally I think it's probably easier and in some cases faster, in fact, doing a full root replacement using a homograft. Again, the risk of extensive patch reconstruction is you can end up with quite a small neoannulus, with again the risk of patient prosthesis mismatch if you end up with a small stented bioprosthesis or mechanical valve. So the homograft aortic root or freestyle root or the Ross procedure are options as biological valve substitutes. A mechanical Bentor is also an option in some cases. And there are more complex operations, including the Danielson and the Commando procedure. The homograft is a very versatile and surgeon-friendly substitute. It allows you to suture pliable tissue onto the healthy muscle of the LVOT, and the sutures do not have to be tied with high tension, whereas if you're suturing a Dacron tube graft onto the LVOT muscle, one finds that you have to be a little bit more aggressive with your tying to secure the graft down there, which of course can be a risk for tearing the muscle and leading to a very difficult situation. The homograft also allows you to reconstruct the aortomitral continuity by using the donor anterior mitral leaflet, and this is a very elegant way of dealing with what could otherwise be quite a difficult situation. I think the homograft is generally more hemostatic than synthetic aortic root replacements. And there is fairly good data to show that the freedom from reinfection is superior with homografts in the medium and long term. The downside of homografts, of course, is that it does depend on surgeon experience and availability of the homograft, and also the late reoperation can be particularly challenging due to heavy calcification. So if you're dealing with a young patient, you may be storing up problems in the future when it comes to the re-operation. Generally speaking, with root replacements, we deal with the coronaries using the button technique, where we reimplant the left and right coronary buttons to the side of the homograft or Dacron tube. Very occasionally, with very destructive endocarditis, it's very difficult to guarantee an effective anastomosis when the button is extremely fragile and friable. And very occasionally, one has to resort to oversewing of the buttons and performing a triple bypass concomitantly. Very rarely the Cabral can be used, although in recent years this has gone out of fashion because of the high incidence of medium and late complications. The Danielson is a variation on the theme of a Benthal. A length of Dacron tube is basically intersected, a bit like the first step of performing a classical elephant trunk procedure. A prosthetic valve is then sutured to the folded margin, and then the Dacron tube is elongated. The lower margin is then anastomosed to the LVOT, and the upper end, of course, is connected to the native ascending aorta. Now, the result of this is that the prosthetic valve generally lies much higher than the anatomical plane of the annulus, and consequently, the coronary ostia have to be translocated quite high up, obviously above the prosthesis, and more often than not, this has to be done with the use of interposition grafts in the form of venous grafts or sometimes synthetic grafts, similar to the Cabral. Finally, the commando operation in cases of double valve prosthetic valve endocarditis with destruction of the aortomitral fibrous body. Here, there is a need to radically remove and debride all the infected tissue, including the two prosthetic valves, and creating, if you like, a single chamber between the aortic root, the left atrium, and left ventricle. This requires, of course, opening the roof of the left atrium as shown in the diagram on the left. The mitral prosthesis is then sutured into the posterior mitral annulus in the standard fashion using pledgeted interrupted horizontal mitral sutures, but the anterior third of the mitral prosthesis is used to suture a double layer of bovine pericardium to create a superior and inferior patch. The inferior patch is used to reconstruct the roof of the left atrium, as shown in the diagram on the right-hand side, and the superior patch is used to facilitate implantation of the aortic prosthesis and to recreate the non-coronary sinus in the form of a patch augmentation repair, and then finally the aortotomy is closed and the procedure is completed. Now, this is obviously a very complex operation and does demand skills of a very experienced surgeon and ideally 2 experienced surgeons. But in some cases, really, this is the only alternative for patients with very severe, very complex prosthetic valve endocarditis. So I will stop there. I'd like to thank the Society committee members for inviting me today, and I'm very happy to take any questions from the floor.
To the end. I would encourage the audience to participate in the polls, please, and keep sending us your questions on the Slido. Torsten, do you want to introduce the next speaker, please?
Yeah, thank you. The next presentation will be on the Ozaki procedure, the Ozaki operation for acquired aortic valve disease, technical considerations, and the evidence, and it will be presented by Karen Booth.
Good morning, everyone. I would like to thank the organisers of the SCTS INSQ University Day for 2021 for asking me to come and talk to you about the Ozaki operation for aortic valve disease, technical considerations and evidence to date. For those that don't know me, my name is Karen Booth. I'm one of the consultant adult aortic surgeons and cardiothoracic transplant surgeons at the Freeman Hospital in Newcastle. I'm a UK NTN trained in Belfast and at the Freeman jointly, and I'm presenting to you as part of an Ozaki team, which is made up of myself as the adult surgeon and also Fabrizio and Mohammed, who are my 2 paediatric counterparts. So where did Ozaki start? Well, it started with Professor Ozaki, as we know. It's also known as the AV neo procedure or neocuspidization of the aortic valve. It was first introduced in 2007 in Japan when Professor Ozaki designed the concept himself and started to implement it in the majority of the patients he operated on. It was transferred then into Boston, the Children's Hospital, in 2014, and following continued international success, it made its way into the UK in 2016. Neocuspidization is a concept in which pericardium autologous is fixed in glutaraldehyde, and then it's just the leaflets that are simply stitched onto the annulus. You preserve the aortic root expansion in systole, and therefore you offer the patient improved hemodynamics. There's no sewing ring, nothing fixed at the base of the annulus, therefore the largest possible effective orifice area is achieved. That allows for annulus motion, improved hemodynamics, no need for pacemaking, and more importantly, avoidance of warfarin, and actually really cheap. It's £1,000 per procedure, and there isn't really an aortic valve or certainly a TAVI that can compete with that. If we really want to test in a surgical procedure, we really want to know about freedom from reoperation, we want to know about long-term outcomes for patients, and we want to know if we can restore natural life expectancy. And that's why the majority of this is taken off for this procedure in the paediatric population. For that population that you really want to avoid the mechanical aortic valve. And when Professor Ozaki first introduced it, he thought about the small aortic annulus. He really wanted to avoid PPM, especially in that more elderly, short lady who's got a higher body surface area. And also for patients who just simply don't want a mechanical valve, who just do not want to have the lifestyle restrictions that come with it, who perhaps want to play a lot of sport or be particularly active, and a tissue aortic valve is just not a good substitute for them. So he has 850 patients in his series from 2007 to 2015. And that's the thing that really struck me, was that this was a high volume surgeon who really, this was his aortic valve of choice. He didn't just select out patients. In reality, what he did was he did it for every aortic valve that came. That allowed him to really, really standardize and to have some modifications through the years. So it's really important to understand his results before you start on a program yourself. Mean age was actually 71, so the population that we would just put a tissue aortic valve into, and you can see for the bulk of patients, it was an aortic stenosis and a tricuspid aortic valve. There's only about just over half of his series, which is an Ozaki procedure alone, and he didn't preclude it from concomitant procedure, which is important to note. We all know that Professor Ozaki's results are excellent, and it's the standard that we're all aiming to achieve to show that it's reproducible. And you can see that infective endocarditis is low, reoperation rate is low as a percentage of per patient year, and you can also see that survival is very good. He has never really converted into a tissue aortic valve replacement intraoperatively, and that he uses it for aortic stenosis and aortic regurgitation. He does not offer aortic cusp repair in the younger patient. He just does an Ozaki procedure for everybody. But you can see the cross-clamp time is much longer than a standard AVR, and his mean cross-clamp time is 106 minutes. In terms of survival, cumulative incidence of reoperation, which is shown in graph B, and most importantly, cumulative incidence of recurrent moderate or greater than that aortic regurgitation are all low. So extremely comparable with repair results and extremely comparable with survival following prosthetic valve implantation. The technical changes I referred to through time and experience was the changing from the rough to the smooth pericardial edge as it hits into the LVOT. He did a 5mm wing extension that was to support the new commissures, especially in that bicuspid aortic population. And then he came to the understanding that the cusps move better if they're equally sized. And so the idea is that that better cusp motion is also query linked to thrombogenicity, so you avoid any clots that may form on the valve. But just when you're starting to think about bringing Ozaki into your unit, an AVR is very straightforward. You can do 3 of them in a list. Very difficult to do 3 Ozakis in a list. Your average cross-clamp time for an AVR is usually less than 40 minutes. You can get down to 20 to 30 if you use rapid deployment technology. AVRs can come with minimally invasive options, more difficult in an Ozaki because you'd need to do a VATS harvesting, which would be bilateral procedures before you go on and take on your mini sternotomy. We also need to consider how many aortic valve replacements we do in the UK, how many tissue valves we do, and how we keep pushing the boundary. We keep saying that it's okay to just want to avoid warfarin and put that tissue AVR in the younger population. We need to consider that there's new technology for bovine pericardium, which is available through certain companies. But we also need to know that we still know that in the young patient, the Ross is the ideal. We also know it's not widely available, and we also know that some people will argue that it's replacing one valve pathology with 2. And so we need to think about, should this be the standardized reproducible AVR for all? Should it be limited on age? Should it be limited just to certain surgeons? And what way should we really roll it out responsibly? Our journey has started in July 2018. That publication and presentation at AATS really caught our eye. And we thought this is something that we'd really like to bring to Freeman. It's important to know that once you do your training, Professor Ozaki actually comes and first assists you and signs you off in 2 cases, so that he knows that he is offering something out that is reproducible. You will always take enough pericardium. It will always be the thing that you will worry about. You'll clean the rough surface, and the best way actually to do that is just with a swab at the start. If we start cutting the pericardium, just push the fat out of the way. Probably not an issue in the pediatric population, but in my population, certainly pericardium needs cleaned. Professor Ozaki recommended a harmonic scalpel, but I just do it now with scissors and a swab, and it works quite well. Pericardium gets fixed, and one of the questions we asked is, how do you get hold of glutaraldehyde? It's not widely available in the UK. Ours comes through pharmacy department and is flown in from the States. If you read the papers, he'll tell you to fix it for 10 minutes. We've brought that right down to 5 through our own experience. And then we rinse it off for 18 minutes in normal saline. Usually by the time you clamp, give the plage, cut the valve out, you've had enough time, but just remember that's nearly 35 minutes of prep time before the pericardium is ready to be used. Taking out the cusps. Really important that you preserve that aortic annulus. You need to have something to stitch to. He recommended QSA to us, which actually our HPB surgeons use, and we did give it a go. But again, very cumbersome to set up, takes a bit of extra time. Nothing wrong with a pair of rongeurs. Most of us preserve aortic annuluses in our normal aortic valve population, so actually it's been quite easy just not to do that. And as time has gone on, we've really simplified as much as possible just to get that cross-clamp time down to more reasonable numbers. So sizing of the cusps. So these are sizers that have been designed by Ozaki. They are unfortunately disposable. We still think if they could be sterilized, you can make this procedure even cheaper. But the sizes relate just to the intercommissural distance. So to just show you an example of a sizer, so you take like a straight stillies or straight clamp, you clamp onto the sizer and you go through the different sizes. You do eventually get used to what size you're looking at. Obviously, that's the biggest learning curve. You write down the size for the non, the right, the left. And this is especially applicable in that bicuspid population. What you want to do is know what the total size would be and then divide it into 3 equal cusps. And that's really how we've standardized that out for better cusp motion and less likely to have aortic incompetence at the end. This is the windmill effect, is what it should look like at the end of the procedure. But you can see it's lovely in that it's completely flexible, the aortic root. It's got normal hemodynamics, normal motions and systole and diastole, and that's really what you want to achieve. So I've just got a small video here, just shortened down into just over a minute and a half, just to show you what it's like on the day. I obviously didn't want to play a 100-minute cross clamp time to you, so this is just all the main steps put together. So the ideal valve substitute, is it the Ozaki valve replacement? Well, I'll hopefully by the end of the presentation let you a little bit clearer into what your thoughts are on that. But what you really want to do is mimic characteristics of the normal valve. You want excellent hemodynamics, long durability. You want low rates of reoperation. And you want high thromboresistance. You really certainly want to know that there's less chance of endocarditis after the procedure. And I think really ideally you would like to get to a stage where we're going to be able to offer normal life expectancy. And really the only valve that offers that now is the Ross operation. So this is just to sort of bring to the forelight, if you're just thinking about whether or not this is a discussion that took place back in 2014 after a publication, just looking at, is a tissue aortic valve replacement someone less than 60? Is it better to do a cusp repair in the regurgitant population, or should we be offering a tissue valve? And it's really this percentage of freedom from reoperation in the AVR less than 60 that you need to consider. In actual fact, is it really responsible to put a tissue valve in at that stage? And I know that technology has moved on, but if we just have a look at what we have been offering and just asking ourselves, is this the right thing to do? We know that the Achilles heel of all of these procedures, whether it's isolated cusp valve repair or whether it's the Ozaki operation, will be that conversation about reoperation rate and then about valve durability in the longer term. So what is the standard of surgical care in the UK today? The isolated aortic valve replacement. It's extremely common for a tissue valve to be used. This is pre-publication data. It's now been accepted. And I thank Professor Giangarini for sharing that with me. It's nearly 20,000 aortic valve replacements. From most of the units in the UK, we all submitted our own NICOR data. This is the best information that we have, and you can see that 70% of patients have had a tissue aortic valve replacement, that's sort of regardless of age. So in actual fact, we are all as surgeons keen on tissue aortic valves. It is the thing that we're more than likely to recommend, and although we talk about patient choice, the reality is of what we do is that we offer tissue valve aortic replacement. The mortality for isolated AVR is 1.9%, and in some units I'm sure will be even lower. The sternotomy for bleeding rate is about 4%, stroke is 1.1%, and for an all-comer population, this data is extremely comparable with the TAVI data, and you can see that reoperation for valvular problems, like such as significant paravalvular leak or early endocarditis, is low. Sorry, that's just the same slide from before. So if we just then look at Ozaki, the biggest series in the UK is across 2 centres, 55 patients and a median age of 58. This is a really interesting paper that Umberto did that just really kind of has a look at, well, can we compare this Ozaki procedure to what the standard tissue valves are? And really the outcome of that was just that the Paramount Magnet E's had the best in terms of structural valve degeneration over time, in terms of reintervention and endocarditis, and that the Ozaki patients that they looked at, just with follow-up out to 1 year, had extremely good hemodynamic results. So this paper was done to look at the outcomes of aortic valve Ozaki procedure using autologous pericardium in the adult population, and it was the hemodynamics that they found that were so excellent, and it's the thing that I would say is really impressive about the procedure. They considered a safe and effective alternative for treating aortic valve disease, but at the minute it still offers a reoperation rate that a tissue aortic valve replacement would not do in early into the series. So we started July 2018. I'm going to present you 2-year results. I'm going to present you pediatric and adult results and the full spectrum of congenital and adult disease, which is actually rare and is not in publication in anywhere else. So we've done 35 cases. Like I said, we've gone slow and steady with an age range of 9 to 72, and the bulk of our patients sit in the age range of about 30 or 40. You can see that 71% of what we've operated on has been in the slightly more technically challenging group of the bicuspid or the unicuspid, and we haven't precluded people if they've needed concomitant procedures, and it's not a surprise to find with our congenital patients that actually a lot of them have needed ascending aortic replacement concomitantly. If you look at the cross-clamp time, mean cross-clamp time of 135, and remember Professor Ozaki's out to about 8 years was reduced to about 101. If you just look in brackets there, the range, 91 minutes is the quickest I've done an Ozaki isolated procedure, and you can see that you can get that cross-clamp time down with experience once you get to streamline bits of the procedure. And that was the things that I had said before, like removing the CUSA, getting rid of the harmonic scalpel, just going like straight back to basics. And getting used to the sizing of the cusps. That all takes time. We haven't lost any patients in our Ozaki series, and this is a wee bit more about the morbidity that comes alongside it. So the mean age is 31. We haven't taken a patient back to theatre for bleeding, 1 blood transfusion, 1 patient with postoperative AF, never needed to put a pacemaker in. You can see from the age range that it's unlikely that we would have had a stroke, which we haven't had, and the gradients across the valve are fantastic. A lot of these patients go home on day 3. A lot of them go home feeling an awful lot better, and also don't really disagree with discharge either. They feel like they're ready to go home, which is something that I would note. And if you just look at the reoperation, so the freedom from reoperation is sort of comparable to that aortic valve cusp repair. But in reality, I think if you look at the 2 severe aortic incompetencies, so we've had 4 reoperations, that's 3 in a pediatric population and 1 in the adult. And you can see that it's a real learning journey for your team. I think that's the thing that I would say about this, is that TOE at the end is extremely important. Until you get to know what it should look like, you need that TOE to really confirm it for you. So even now, the changes that we've made have been an addition of a regular cardiologist, a single cardiologist who comes and looks at every Ozaki procedure, and that's the best advice that I can give in terms of making sure as you move forward that you can negate any problems that you can come across. So it's reproducible, it's standardized, it's got very good early outcomes, and the Achilles heel of it will be the reoperation, and that's the thing that we need to get down to as low a standard as possible. But these are 2 of our Ozaki patients, and this is just like 3 or 4 months post-operatively. And Gary on the right is one of my first adult patients. And Gary is 42 and he's a salesman and lives a really active life. He came back to clinic at 6 weeks and said to me, I want to go on holiday to Tenerife tomorrow. Is that okay? I don't see that in my standard aortic valve population. And I think that's the thing that's sort of difficult to get across unless you really do the Ozaki procedure. But it's a really lovely operation. And hopefully in the future, will keep that really good standard of long-term durability. And so hopefully will become the valve of the future. There are things that we need to do. I think are really important. I think it'd be really good if we could have a UK Ozaki registry. I think it's really good SCTS are supporting us today to come and talk about the procedure, and as many units as possible are encouraged to share the results. We need to know things like the revival RCT outcomes. We need to know where Ross is going to sit in the future. We need to know what's going to happen with TAVI. There's evolved aortic stenosis patients, and we've got one of those in one of our studies. So are we going to widen access for aortic valve intervention to those that are even asymptomatic? And then we really need to get better at looking at frailty and knowing, can we streamline patients into all the options that are available, such as TAVI, Ozaki, standard aortic valve replacement, and then really trying to figure out in the future where everything's going to fit and lie. So I'd really like to thank you for paying attention, and if you've got any questions, I'd be more than happy to take them. Thank you.
Well, thank you so much. I think, Omar, you want to take over?
Yeah, thanks for that presentation, Karen, and we'll keep all the questions to the end. I'd like, with great honor, to introduce the next presenter. It's Professor Laurent de Kerkhoff from Hôpital Saint-Luc in Brussels. I was privileged to work under him and under Professor Al-Khoury during my fellowship there. Laurent has done a lot of great work on the anatomy of the aortic root and the annulus, and he'll be presenting this data today. So let's go.
Ladies and gentlemen, dear colleagues, it's a pleasure to participate today to SCTS UNESCO University 2021. I have been asked to speak about anatomy and dissection of the aortic root for aortic root and valve repair. I have no disclosure. As you know, the aortic valve and the aortic root present tight relationship that are necessary for its good function. This relationship need to be preserved or restored during aortic valve sparing and repair surgery. The aortic root is embedded deeply in the different cardiac structure, and you can appreciate here the tight relationship with the aortic root and the right ventricular outflow tract, but also the continuity with the mitral valve and the left atrium, and also on one side the continuity with the membranous septum, the tricuspid valve, and the right atrium. Now, when the root is completely free, you can appreciate here that you have access circumferentially to the sinotubular junction and the basal ring, which are important structures that need to be restored in terms of sizing during valve repair and sparing surgery. Looking from inside, the aortic valve sits on what is called the aortic annulus, composed by its half by the fibrous continuity between the mitral valve and the aortic valve, and on the other half sit on the interventricular myocardium. The membranous septum stands in the commissure between the right and the none, and the conduction system rise from it, from the trigone to the interventricular septum crest. Sinotubular junction stands a couple of millimeters above the commissure. The ventricular aortic junction is the continuity between the cardiac structure and the aortic root. And the basal ring is the plane passing through the nadir of the tree leaflet. The interleaflet triangle stands below each commissure. It's delineated by the leaflet insertion and the basal ring. Now, the aortic root has a specific dimension in normal individuals, This dimension range from 21 to 26 for the annulus or ventricular aortic junction, 30 to 34 for the aortic root, 26 to 29 for the sinotubular junction. This dimension may vary in function of the body surface area, height, weight, and age of the individual. It has been shown that those dimensions also are enlarged in presence of aortic regurgitation, and they increase in proportion with the severity of aortic regurgitation in average. So, and this is the case, and this has been demonstrated in tricuspid and in bicuspid aortic valve. In our experience also, we show that the patient operated for AI or aortic root aneurysm presented larger annulus, and this was also observed by measuring the annulus by three-dimensional echo. Also, the oval shape of a normal annulus tends to become more circular when the annulus is dilated. Also, we show that in presence of severe aortic regurgitation, the annulus is larger than compared to the patient with fewer regurgitation. And the largest annulus were presented by patients with bicuspid valve and severe aortic regurgitation. That's why, since now almost half of a century, surgeons who were repairing or preserving the aortic valve have proposed techniques of anuloplasty, and many techniques has been described. Those are the 5 more used techniques nowadays. 4 of them are circumferential, and for 3 of them, external root dissection is necessary. For the reimplantation and the external ring techniques, certainly the external root dissection need to go the deepest. So how to reach the basal ring? How to reach the basal ring by external root dissection? We have to pass through the autoventricular junction, which has been described to be more cranial to the basal ring. But is it really circumferentially and parallel to the basal ring? The author of this schematic described it a bit differently later on, and it seems to be not really parallel to the basal ring, but its relationship, its topographic relationship was not very well known until we performed this study. In the same time, another very similar study was done by the group of Emmanuel Lansac in Paris, and we observed very similar results in both of our studies. What did we show in those studies? We showed that in reality, the ventricular aortic junction is at the same level and follow the basal ring on the fibrous portion of the circumference between the 2 trigones. On the side of the muscular septum and membranous septum, the ventricular aortic junction raise a little bit above the basal ring for approximately 4.6 millimeter in the commissure between the left and the right, and approximately 2 millimeter half behind the right sinus and in the commissure between the right and the none. So in consequence, if external dissection need to reach the basal ring, the target of our anuloplasty, will need to dissect deeper than the ventricular aortic junction level on the side of the muscular septum. So this is example of dissected aortic root. You see in yellow the limits of the ventricular aortic junction, the anatomical ventricular aortic junction. We have dissected a little bit more deeper caudally to reach what we call the basal ring. And to do that, we have found a plane of dissection between the right ventricular outflow tract and the interventricular septum. At the most deepest part of our dissection are placed the stitches that will anchor the external ring or the vascular graft in those techniques. So this is the way we'll place our proximal suture line in a valve sparing surgery. We'll go horizontally along the basal ring. Only at the level of the membranous septum, we are putting the stitch a bit more cranially, following the ventricular aortic junction to avoid the conduction system. So this a movie of an external root dissection in a tricuspid aortic valve. So we always start by dissecting the non-coronary sinus, where the dissection is probably the easiest, because you just have to cut the epicardial reflection, and the ventricular aortic junction stand at the level of the basal ring. The sinus wall is resected. Here, the right coronary ostium is isolated, and we dissect behind this commissure until the roof of the membranous septum. Then the left coronary button is individualized. We fix the ostial cardioplegia cannula this way, so the remaining of the surgery can be performed giving cardioplegia every 15 minutes, as we generally give warm blood cardioplegia. Now we carry out the dissection on the level of the left sinus, where basal ring is easily reached. Here we detach the pulmonary trunk from the anterior commissure of the aortic valve, and we arrive in this space here, in this plane here, between the right ventricular outflow tract and the interventricular muscle that stand here below. And we will do this dissection like we would do when harvesting a pulmonary autograft in a Ross procedure. So surgeons doing Ross know very well this maneuver, where this plane of dissection is well seen, and it is extended toward the membranous septum here, a little bit detaching the right ventricular outflow tract from the interventricular septum. And now the root is completely dissected, we measure the geometric height of the valve. We also measure the height of the commissure, and those two measures help us to determine the best graft size. We place all the proximal suture line and you can appreciate how deep we are going. We place the stitch really at the deepest point of our dissection to follow exactly the basal ring. Here we start going a little bit cranially with our stitch to avoid the conduction system and the AV block postoperatively. And this is how we perform our proximal suture line in a tricuspid valve. This video represents the external root dissection in a bicuspid valve. We start by the non-coronary sinus, where dissection is relatively straightforward to the basal ring. The sinus is resected. We leave 5 mm of aortic roll along the leaflet insertion. We isolate right coronary buttons. And left coronary button. We place the cardioplegia cannula, and then we detach the pulmonary trunk from the anterior commissure, which correspond to the raphe here. We arrive in this area where there is always some fat and tiny veins that can easily be coagulated. And then we reach the plane of dissection between the right ventricular muscle and the interventricular muscle. And this plane can be continued for about 1-2 centimeters safely. There is very few things to ensure there if the plane is followed. If a hole is created in the right ventricular outflow tract, it can be easily closed with a 4-0 prolane. Also, the proximal suture line stitch can be placed far from beyond the hole in the right outflow tract, and by this way close the hole. So this is how we place the proximal suture line at the deepest point of our dissection. And here we go a little bit cranially to avoid the conduction system. Here, the dissection in an external ring Anuloplasty, you can appreciate the tricuspid valve with left coronary cusp prolapse in a very normal root size. Anuloplasty needs to be performed in such situation, and it is more stable if we perform circumferential annuloplasty compared to Cabral stitch. So we start the dissection on the side of the non-coronary sinus. We create a channel between the coronaries. Here's the right coronary. We dissect between the pulmonary valve and the aortic root. We will look for the same plane of dissection as during a valve-sparing root replacement. Of course, care must be taken while creating this channel to do not catch the coronary and kink the coronary while passing the stitch or the band. It has been described. This maneuver needs some experience. In my opinion, this maneuver is more difficult than the root dissection when the coronary are detached. So in a certain way, it's more easy to perform a valve-sparing root replacement than this technique where placement of the proximal of the suture is more difficult because the risk of catching the coronaries is higher. You need some experience with root dissection in valve-sparing surgery before to perform this kind of external root dissection while you preserve the sinus of Valsalva and the coronary attached to the root. But the suture line is the same. You follow the basal ring horizontally and you go a bit cranially at the level of the membranous septum. When all the stitches are placed circumferentially, you can use a Dacron ring, or here it is a simplicity band. You can also use a Gore-Tex shunt of 3 mm, the pediatric Gore-Tex shunt. These are all material that are very suitable to do an external ring. Sometimes it's more easy if you use a Dacron ring because it is calibrated. You can decide the circumference the diameter that you wish. The stitch are passed through the band. We tie the stitch on the side of the muscular septum first. Then we tie the stitch on the side of the membranous and the mid-aortic continuity with a Hegar dilator in place, and so you calibrate the reduction of the annuloplasty by placing a 23 or a 25 mm Hegar, depending on the size of the patients. The last stitch to tie is used to close the ring, and that's how we are performing an external ring. Of course, when you perform external root dissection as deep as in those techniques, you have to be aware of the trajectory of the coronary arteries, and you have to be aware of eventually abnormal right coronary artery that generally pass behind the anterior aortic valve commissure, or abnormal circumflex coronary artery that can raise from the right coronary, and that generally go around the aortic root on its posterior aspect, here descending towards the basal ring at the nadir of the non-coronary sinus, and that go its way here behind the aortic root. So in conclusion, a good knowledge of aortic valve and root anatomy is mandatory to perform root dissection safely. The goal of root dissection is to resect the sinus of Valsalva and to reach the basal ring to place external anuloplasty, external ring or graft for the reimplantation. On the fibrous portion, the ventricular aortic junction and the basal ring are the same level. On the muscular septum, the basal ring is deeper than the ventricular aortic junction. And at this area, you need to perform a dissection that really look like the pulmonary autograft harvesting in Ross procedure. Thank you very much for your attention, and I'm very pleased to discuss this topic with you during live discussion.
Okay, thank you very much, Laurent, for a very interesting presentation. Can I ask all the speakers to come to the stage, please? Okay, I think we have everyone. Laurent's not there, but he was saying he was having some issues earlier on with logging on. Great. To start, we start the questions. We have some questions on the on Slido. So there's a question to Mr. Briffa about the anticoagulation policy and whether if we lower anticoagulation policy, there's a risk of increasing pannus growth. Do you have a comment on that?
Hang on. Yes, very good question. I don't think there's any evidence to state that pannus is related to anticoagulation. I mean, pannus is pannus. It's fibrous tissue. It's not old clot. And pannus as a problem in aortic valve replacement with a mechanical prosthesis is very, very uncommon. Tends to be something associated with a mechanical valve replacement. In the old trial, so the first trial I quoted, which was the American VA trial, and that's with old mechanical valves, Bjork-Shiley. I think the need for reoperation due to mechanical issues was either 0, 1 or 2, certainly less than 5. And this is over 500 patients followed for 15 years. So it's extremely rare after mechanical AVR. So in answer to the question, no, I don't think it's related to anticoagulation pannus formation.
Okay.
So Norman, if I may, on that aspect, you mentioned the DOACs and the possibility that may be an option for mechanical valves in the future. How would you address the perioperative phase? Because, without the antidote that we have not yet.
Yeah. I mean, that's a very good question. I suppose it's like we manage AF patients, bridging. They just have to come in, stop it so many days before and go on heparin. So it's something that most certainly in the United Kingdom are well versed with, the concept of safe bridging.
No, I mean the post-operative phase, because if you have the sudden need for pericardial infusion to reoperate, but you have them already on DOACs, that might be a problem.
That's true. That's true. But again,
it's manageable.
It is manageable. It is manageable. I mean, we operate on loads of patients on DOACs. I mean, we in a cardiac surgical population, so many patients are have the atrial fibrillation, have persistent long term, and are on DOACs. So it's something that we've learned how to manage with.
Great, thank you very much. Mario, I have a question for you. And in the meantime, Karen, get a drink of water because there's an avalanche of questions coming your way. So thank you so much for your presentation, Mario. Very interesting. Now, I know you're a very accomplished surgeon in proximal surgery in endocarditis, but you also, I know that you performed the Ross procedure. So when would you offer a patient with active endocarditis the Ross procedure?
Thanks, Omar. I mean, I think the true answer there is rarely. But again, if you're dealing with a young patient, sort of late teens, patients in their 20s, particularly females, and you are definitely looking for a biological solution, and the degree of endocarditis is extensive, necessitating some form of a root replacement, then I think the Ross is an option. And obviously you need the right team around you and have that sort of experience, because obviously it adds an extra layer of complexity to what is anyway, a challenging operation. So I think it just requires careful consideration, but there are a few patients, I think, in whom it's the best option, I think.
Yeah. Would you say that the decision becomes a bit easier if the patients are a bit more maybe in a bit of a subacute stage where they're not overtly septic? Is it because we do the commando procedure here in Liverpool, and we use homografts very openly, and we've recently introduced the Ross program, and we feel that the autograft would probably be the ideal substitute in this young cohort if they have endocarditis. But our worry is the long operation times and the plegia times.
Yeah, no, that's right. So you're right. I mean, you have to look at the general clinical picture, holistically. So, if the patient is profoundly septic going into the OR, already on noradrenaline and struggling just to maintain their mean blood pressure, sure, ideally you want to do the shortest operation possible. But if the patient is stable and they've had a good period of antibiotics and they're not overtly septic, then yes, I think that buys you a bit more time, doesn't it? And gives you a bit more confidence to push the envelope a little bit.
Yeah, thank you. Okay, Karen, are you ready? So a host of questions. A couple of questions related to the glutaraldehyde fixation and how that affects the long-term effect of calcification on your pericardium. So you were probably expecting that. There is a very good question about case selection. Are you dishing it to everyone, or are you still, because you're in the early stages and the learning curve, specific about which patients to offer it to, and what are your criteria? And then Laurent has asked a question about comparison to the Ross, but I've got similar questions as well.
Sure. Okay, so you recommended that your glutaraldehyde fixation is for 10 minutes, and it didn't actually take us that long into the series to reduce that right down, especially in the pediatric population, and that was because of leaflet stiffness. And obviously stiffness would equate to calcification over time. And the gradients, interestingly, were still quite low, and so we know that will impact on degeneration over time. But actually now we only really fix for between 2 and 5 minutes, depending on whether it's a pediatric or an adult patient. I think that is a really good question. There's a very definite technical difference when you're stitching with it, though. So if you fix for 10 minutes, the pericardium is definitely less pliable. but sometimes easier at the beginning. And then as we've got more experience, that hasn't been an issue. What was the second? There's one about Ross, wasn't there? So I'm a huge fan of Ross. I don't perform it, and I understand that its best results are limited to surgeons who do it regularly and have high volumes of it. But it's not that I feel that Ozaki is ever going to take over from Ross. It's just that I think things like the Revival study will really tell us, because that's going to be a randomized prospective control trial, and Ozaki will sit in that. So that's a Ross operation versus any other aortic valve replacement, and that might help to answer some of those questions.
Okay, thank you very much. There was one question about case selection. How are you selecting your patients now before you?
So you can see from our results that average age there was about 31. So we really are trying to select out for the younger patient who ideally would like to have the biological valve. We think would be more responsible to offer the Ozaki rather than a tissue standard valve. But actually, if you read the series in the literature, it's actually probably better to start off in a tricuspid population, slightly older even. Ozaki's results himself has a mean age of about 71. It's certainly more technically challenging if you've got a uni, quadra or bicuspid valve. So the learning curve is a little bit steeper in that patient population. But for us, we've been offering it to people who want it for the right reasons. But I would say if you're starting out, that's not really a bad strategy to have tricuspid older patients.
Okay, that's great. I think one word of caution about the Revival trial, because I have good connections with Professor Al-Hamamsi, who's one of the co-founders of the trial, and he's actually told me he's gonna pull out, because I think if you want to compare the Ross to other aortic valve substitutes, you really need to look at long term. Because I think that's where the Ross really plays part. It's the long term. I think in the short term, I don't think the trial is going to be powered enough to tell us much. But we'll obviously see how that pans out. There's one question I wanted to ask you about the hemodynamics following the Ozaki. You've mentioned you've seen excellent hemodynamics equitable to normal valves. But if you actually see Ozaki's midterm outcomes in the JTCVS paper, they've quoted peak gradients of 19 plus or minus 10 at 1 week, and at I think it was 3 years came down to 15 plus or minus. So have you seen similar gradients? I know it's probably related to the heights of the leaflets because you use really big leaflets. So have you seen similar gradients or not?
So that relates, I think, to the glutaraldehyde fixation. So Ozaki still fixes for 10 minutes, and I think that to our mean gradient across that valve sit. I mean, the last one that I did had a mean gradient of 5 at the end of the procedure, and I've never noted that there's a higher gradient that then dropped, maybe intra-op to the initial, but that's to do with fluid status and cardiac output. But if you actually look at your initial first week post-op echo that they get before they go home, gradient is low, but that's one of the reasons why we don't fix for as long glutaraldehyde. Okay, so yeah, that makes sense. And I think one final question from me. We've all seen the worst results with valve repair when we're using pericardial patches. And to be completely honest with you, I know that Ozaki has it. We've only seen midterm results up to now, because I think the numbers, although he's been doing it for 12 years, but the numbers at risk and the numbers needed to treat are very small. So we can only make deductions on the midterm. But definitely they're better than selective leaflet repairs with pericardium. Do you think this is an influence of just the fact that you're replacing all the cusps so they all harmoniously work together better? Do you have an explanation for this? So I think that it's an explanation of a standardized, reproducible surgical procedure. And when you talk about isolated cusp repair and use of a patch, that is not standardized in any shape or fashion. And you've got lots of very different techniques and different surgical approaches to it. But the thing about Ozaki is that regardless of the etiology of the aortic valve disease, it's a bit like the Ross, it's a standardized approach to that. And I think that's why the results are so reproducible. But I completely agree, we've got no long-term results, and I think that durability is the question that all patients deserve to have the answer to, and the best for that at the minute is definitely the Ross.
I think, Omar, if I may make a comment, the point is that a lot of people think that Ozaki procedure is a valve repair, but there's a famous discussion between Jochen Schäfer's and Ozaki, where Ozaki said, he published this as a repair, and then Schäfer said, this is not a repair. He said, well, the reviewers at JTCVS accepted it, and so the Schäfer said that just because you've crossed a red light and you haven't been caught doesn't make it legal. So I think that's the thing. So in terms of comparison of long-term durability, I think we should compare Ozaki not to repairs, but we should compare them to the classic replacements. And
yes.
And there, with the 10-year results, they're just what you would expect from a regular prosthetic valve right now. I mean, so you're perfectly right. We need to wait.
Yeah, I agree, Torsten. I agree. It's not a valve repair; it's a replacement. But it's just it was a bit peculiar that the leaflet, the pericardium, seems to live a bit longer with the Ozaki than when used in leaflet repair. I think Mr. Briffa has a question.
Yeah.
No, actually, sorry, I've had 3 messages that we are running out of time.
Oh dear.
Okay.
Mr. Briffa, very sorry about that.
Don't worry.
Before we go, I just need to make some closing comments. First of all, profuse apologies from Professor Decourceux because his connection is bad and therefore he couldn't join in on the session. Thank you on behalf of all my co-chairs to the excellent speakers and quite a stimulating discussion, which is very short as always. And I would just like to draw this session to a close. Thank you all for attending.
Thank you.
Thank you.
Thanks very much.
Bye.
Thank you.
Bye.